Nekoofar gladly, that gladly share this experience with us, all endodontics in Latin America. The first two were amazing. We were very happy of the results that everybody was commenting with us that they really like this project. So I hope that this will continue and keep growing. Today, we have a special guest, which is Dr. Vivekaggarwal. I'm going to read a brief CV of his experience, and then will start with the session. Dr. Vivek Agarwal is an accomplished academic and dental professional as a professor in the Department of Conservative Dentistry and Endodontics at Jamia Millia Islamia, New Delhi, India. He has made significant um, contributions. Dr. Agarwal played a pivotal role in setting up the Department for Undergraduate Studies, shaping the curriculum and teaching both didactic and clinical concepts. His commitment to dental education and patient care has left a lasting impact on the field. Additionally, during his tenure as an associate assistant professor, he continued to excel in administrative responsibilities and guided postgraduate students in presenting research papers at scientific meetings and conferences. So, Dr. Agarwal, thank you for your time. Thank you for being here. I will give the microphone back to Dr. Nekoofar to continue this session. Thank you.
Dr. Vivek, please share what you want to talk to as an introduction, and then we carry.
A very good day and namaste to everyone. So at the outset, I would like to extend my heartfelt thanks to the Latin American Endodontic Society and the Tehran University of Medical Sciences, represented by Professor Nekoofar. Nekoofar is truly a stalwart in the field of endodontics, and I must admit that I have read almost all his paper on calcium silicate cements. And I really feel honored to be here today to discuss my paper on the back pressure effect on the post-endodontic pain. So before we go deeper into the specifics of this paper, I would just like to briefly discuss and clarify the extent, the concept of this back pressure, particularly how much pressure is generated inside the pulp chamber or the periodontal space during such type of closed chamber injection. So to help illustrate this, I have prepared a very small experimental setup just for this meeting, which I will now share with you with your permission, sir.
Yes, please.
Can you see the image, sir?
Yes, very well, very clear.
So as you can see in this image, there is a fluid pressure gauge attached to the root apex of a premolar. The apex of this premolar has been enlarged to size 30 to transmit the pressure from the premolar to the fluid gauge. An intraligamentary syringe and its needle is inserted into the pulp space, and everything is sealed using a flowable composite to prevent any kind of leakage. I'm also sharing a very short video with you. Can you see the video, Professor Nekoofar?
Yes, yes.
Yeah,
but
it is a very yes, it's not playing. It's not playing yet.
Okay.
It's a very small video. Let me put a context to it. The normal pressure inside the pulp chamber is 0.2 psi. That is the intrapulpar or the interstitial pressure as we call it. Now let's compare this pressure with the pressure inside a football, which is 8 to 15 psi, and the pressure inside your car or your SUV is 30 to 35 psi. So if you fill your car pressure to 60 psi, the tire will burst, right? So let's see how much pressure increases inside the pulp chamber when we inject an intrapulpal injection. One small thing to clarify is that the outer reading of this gauge in red color marks the pressure in psi. So focus on these outer readings. So when I start the video, I'm pressing the pressure syringe and you can see the dial moving.
Wow.
I'll just play it once again.
Wow.
So you can see that with just a single click of the pressure syringe, the pressure inside the pulp space rises much above 100 psi in less than 3 seconds. Dr. Nekoofar, actually, it's not 3 seconds, it's less than 1 second. This fluid gauge is filled with glycerin, which impedes the flow of the movement of this needle. So the pressure rises much above 100 psi in less than 1 second. So this shows the intensity of the pressure exerted in a closed chamber like pulp space or the periodontal ligament space. So with that, I would like to request sir to proceed with the discussion of the paper.
Perfect. Thank you very much. That was actually clear a lot of question, a lot of in advance question that we may have. But on the other hand, I have a short question about what was inside the tooth when you did this test. What was pulp tissue inside it or empty?
No, it was absolutely empty. You see, the
And
pulp tissue acts like a gel. It prevents the movement of pressure from inside the pulp space to the outer periodontal ligament. There was a very old study by Dr. Pashley. He conducted in 1980s, and he performed some intrapulpal injection, and he measured the pressure inside the periodontal ligament. So in a way, he measured the effect of intrapulpal injection on the pressure rise in the periodontal space. So he found that there was no change in the pressure in the periodontal space when an intrapulpal injection is given. So if I put up a gelatinous tissue inside the pulp chamber, I cannot measure the pressure from the apex.
understand. Thank you very much indeed. So what we are going to do now, we are going actually to give a summarize of the paper. And before that, I want to talk about the way that we look at any paper during our critical appraisal sessions. So now I'm going to quickly give you a key steps and expectations that we have from a critical appraisal, especially when we have a randomized double-blind clinical trial like the one that we are going to appraise. So we are looking for a comprehensive appraisal. It leads us to a better understanding of a study validity and also to the applicability of this particular article in the clinical practice. Imagine that we are going to do a meta-analysis in a very near future. So we find this article, we look at that, and we want to decide about, can we put that in and can we include that in our meta-analysis or not? So the way that we look at this article is the way that we are going to practice today. So we are not just going to talk clinically, but we are going to talk very academically to know that how to critically appraise such papers. So first, I want to talk about a quick evaluation of the study, because we have two types of the critical appraisal. One of them is very quick appraisal. The second one is the comprehensive one. We will look at both of them. So first we look at the objective of the study, and we should answer this question: are the research question or objectives clearly defined and relevant to the endodontic field? And then we look at the methodology and we evaluate the study design, sampling methods, data collection, and analysis techniques. So with this, we can also go ahead and find out about the appropriate and robust methodology that the authors of any article, any clinical article or randomized double-blind clinical article claim to do. Then it goes to the result. We assess the presentation and interpretation of the result, and are they clear, well-organized, and supported by enough data, or they just claim something as a result. And then we go to the discussion and the conclusion, and we'll look at the conclusion particularly to make sure that they justify the conclusion based on data and based on their own finding, because without that, we are not able actually to find it out. Are they did actually the conclusion in a good way or not in a good way? So this is actually the way that we always look at this type of the studies. Then it goes to the limitations, and also the limitations that the authors, they already mentioned in the article, are very, very important for us, because it gives us better understanding and better justification of the result. We identify any limitations or biases in the study that could affect the result or their interpretation, because sometimes when we look at the abstract of some study, we may quickly implement that in the clinic, that we should be careful. We should critically check everything to make sure that they are not actually to have any bias. And because the bias, any type of bias, any type of the co-funding variables may have some effect on the result. And what is the potential impact of the study on the practice, policy, or future research in the field is also another important thing. But when it goes to the comprehensive critical appraisal, we may go deeper. We assess the study design. We should confirm the randomized double-blind design, and the study itself should show that they have this randomized double-blind design. Even if they claim such a things and we didn't type it, we didn't print it out in the article, it is not valid. So we evaluate the appropriateness for the research question as well. Then we evaluate randomization. We check randomization methods that we are going to do that with the present article as well. And then we assess the adequacy of the randomization process. And then the blinding procedure. The blinding procedure is very important. We should determine the effectiveness of the blinding, and we consider the maintenance of the blinding throughout the study. It was one of the main questions that some of my colleagues sent it to me and asking me about the present study, that with different types of the injection, how they maintain the blinding through their study, which is also very important. And then we analyze the sample size. We need to evaluate the sample size adequacy, because sample size and the power of the study are very important issue if we want to include them in any meta-analysis or systematic review. We check for the power, and also we examine inclusion and exclusion criteria, because this is also very important. In this study also, we are going actually to ask Vivek about the way that they did inclusion and exclusion criteria. For example, about the presence of the preapical disease, presence of the PDL change, or presence of the periodontal problems. These may change the inclusion and exclusion criteria as well. And then also another important thing is when we want to overgeneralize the result, we need to have enough inclusion of the diversity of different patients to be able to generalize the data to other types of the patient or other types of the diagnosis. Then we evaluate the intervention. We review the clarity and consistency of the intervention, because sometimes with different practitioners, different types of the technique, we may have drawbacks for such a things as well. We also assess the uniform delivery of the intervention, because imagine that we already seen that about the injection. If the pressure of the injection is not standardized, maybe the result is not standardized as well, and the result is not applicable. And the final step for the comprehensive critical appraisal is we assess the outcome measures. We determine the clarity of primary and secondary outcomes, as the authors will claim, evaluate validity and reliability of the measurement tools. For example, in this study, we will discuss about the pain measurement, which may be open to a lot of questions. The way that we are able to measure the pain is very difficult and very subjective. So we analyze also the data analysis method, statistical methods that they use, ensure appropriate tests that they employed in their study. We review the results. We examine participants' flow and attrition rate, which is also very important, and we look for clear reporting of the finding. These days, the standardization of the report is also very important, like the flow chart, consort flow chart, and we should follow same way in different articles. And then discussion and ethical consideration also is the last things that we evaluate and we assess to make sure that we are able to generalize and to apply the results of one study to our clinic. The expectation of the sessions that we want to discuss is to be able to clearly articulate strengths and weakness of this article. We should use the established guidelines for evaluation, and we want to consider impact on clinical practice, and also we evaluate applicability to broader populations. And finally, we want to provide actionable insight based on the findings of the study by Vivek and his co-authors. By the way, it is important also to mention that the team that Vivek Aggarwal selected are very famous endodontists from different countries, and this is also very important. So now what I'm going to do, if there is any question, I'm going to go to the second section of the session, in which I'm going to talk and discuss and give you a summarization of the study. If so far about the way of the evaluation of the clinical trials, double-blind clinical trials, is any question, please go ahead and ask your question. Otherwise, we can go and go to the next session, which is the summarization of the study. If there is anybody that they want to say anything or any comment, please talk.
Can I ask a few questions about the methodology?
Oh, before methodology, let us go further, because now we are not talking about the article yet.
Oh, I'm so sorry. I'm so sorry.
Yes,
Apologies.
of course, we give you time to do that, but at the moment, we just evaluate in general the methodology of critical appraisal, a quick critical appraisal versus comprehensive critical appraisal that we should do in our everyday academic job. With our students, with our colleagues, we should always be critical about anything that we want to read in the articles, and especially for our postgraduate student that I know in different universities now we have group of the students that listen to this session. I intentionally put the introduction always as the methodology of the critical appraisal. So we are going now to, by the permission of all of you, we are going to the second part of the presentation, which is actually about the summarization of the study. Let me share that one with you.
Dr. Nekoofar,
Yes.
I just want to say something about to highlight the introduction section before go to the methodology.
Yes,
the
please.
Introduction section was amazing, was very clear, was from general to particular, but not talking about other things. I enjoyed a lot to read the introduction section of this manuscript. Congratulations to the authors. Thank you, Doctor.
Good. Do you want to tell us something about that while I'm going to share that one? Do you want to talk about the introduction with others? I can share the article itself if you like.
The introduction, usually the authors begin with the definition of endodontics, the objectives of endodontics, always the same statements. But in this manuscript, the introduction quickly go to the objectives and take your hands and go to the empty in the literature. Then I enjoyed a lot this section in particular in this manuscript because the term under back pressure anesthesia was not clear in other manuscripts. In this manuscript was very clear and easy to understand.
That's great. That's great. Good to hear that. It was the same idea of mine. So I want actually to emphasize to some of our colleagues that they were not able actually to read the introduction itself. It's maybe good idea to read it again, because the introduction of this article is very rich and it gives a lot of good information. Thank you very much, Hugo, for mentioning this important thing. So introduction. This study investigates the effectiveness of two different back pressure-based supplemental anesthesia technique on postoperative pain in patients undergoing endodontic treatment for symptomatic irreversible pulpitis in mandibular molars. The aim is to provide insight into optimal anesthesia management in endodontics and the methodology. So methodology, as we already mentioned, is a randomized double-blind clinical trial involving 175 patients. Initial procedure, each patient received an inferior alveolar nerve block with 2% lidocaine and 1/80,000 epinephrine. Then pain assessment, Heft-Parker Visual Analog Scale, VAS, used to measure pain during and after endodontic treatment. And supplementary technique, patients with ineffective inferior alveolar nerve block based on random assignment receive either intraligamentary or intrapulpal injection. So they did randomization. Participants were randomly assigned to different treatment groups to ensure comparability. The study was double-blind, so neither participants nor researchers knew which injection was given to reduce bias. And it was a clinical trial because it conducted in a clinical setting with actual patients undergoing endodontic treatment. And the aim was to evaluate the effectiveness of back pressure anesthesia technique in managing postoperative pain. Initial success was just in 29% of cases for inferior alveolar nerve block. So therefore, intraligamentary injection has happened in one group, and in this group, 70% effectiveness, which is also associated with higher postoperative pain level. They also showed that in intrapulpal injection, the success rate was 100% effectiveness, significantly lower pain score at all assessed interval 2, 4, 6, and 24 hours. And the pain levels, record pain increased in the first 24 hours and normalized by day 3. So as you can see here, when we compare the age, gender, and tooth type between the groups, they try actually to stratify that. And I'm going very soon to ask Dr. Vivek to explain the methodology that they did, because this part also is very important to prevent confounding variables. In the discussion of the article, they mentioned that the low inferior alveolar nerve block success rates highlight the need for supplementary anesthesia technique. However, when we look at the way that they predict the success rate for the sample size measurement, sometimes 50% success rate was expected. However, in reality, they found that it is almost 30%, which we will discuss about that as well. So then intraligamentary injection lead to transient inflammation, or may lead to transient inflammation and increased pain due to the high pressure used during administration. Intrapulpal injection provide immediate anesthesia without the same level of postoperative pain, and the findings support careful selection of anesthesia technique to balance efficacy and patient comfort. Conclusion: intraligamentary injection are effective but may result in higher postoperative pain levels. Intrapulpal injections offer a reliable alternative with lower pain reports, particularly in the first 24 hours post-treatment. And dental practitioners should consider these findings when determining anesthesia protocols for patients with symptomatic irreversible pulpitis. So now we are going to the section 3, in which we are going to discuss about the article and ask our question from Professor Vivek. So now I want to ask the participants if they have any question. They may raise their hand electronically, as I showed now here for myself. And when I see that hand, I ask them to turn on their microphone and talk. Or if they want to talk, they can start talking. I believe one of our colleagues wants to ask a question about the methodology. Anybody? If not, I'm going to talk. Yes, go ahead, please. Vivek.
Sir, a small, Professor Nekoofar, a small thing to correct to you. You said intrapulpal pain was less at all intervals. Intrapulpal, in fact, the intrapulpal pain was increased at 2 hours interval, and it was equivalent to intraligamentary pain. But after 2 hours, the intensity of the pain reduced in intrapulpal group. So at 2 hours, both intraligamentary and intrapulpal had similar kind of post-operative pain.
Okay, at 2 hours.
At 2 hours, yes.
Okay, at 2 hours, they were similar, but at 4 hours, the intrapulpal were better
reduced.
than intraligamental. Am I right?
Absolutely,
Okay.
yes.
Okay. And even after, and it had until 3 days. After 3 days, they were similar again. Yes?
Yes, yes.
Okay.
At 3 days, they were similar. All the three
Oh.
techniques were similar. So there was a thing going on that why we haven't chosen 7 days or 4 days or 5 days or 14 days as a follow-up. So in a feasibility study, which was done prior to this study, we have noticed that the pain reduced after 3 days, and there was a similar pain in all the groups, which was
Yep.
almost 5 to 10 on VAS score. So there was no point extending the study beyond 3 days. So after 3 days, you are correct. After 3 days, there was no difference in the pain scores.
Perfect. Professor Arshad, please go ahead.
All right. Is my voice clear?
Yes, yes, very clear.
Okay, so first of all, I would like to thank Professor Nekoofar for arranging this wonderful global meetup. And I hope to see Professor Nekoofar very soon in our first ever endodontic conference that is happening in Pakistan, Rawalpindi, Pakistan on 15th and 16th of November. And I take this opportunity to invite all of you. So if any one of you is coming, interested in coming to Pakistan, just let me know. Let me know so that I can arrange the invitation letters for all of you. Okay, so Dr. Vivekaggarwal, excellent article. We in Pakistan, we are all fan of your papers. Our residents, we are all reading your papers on VPT and taking inspiration from your group. So thank you very much, sir, for wonderful research over the years. Please bear with me because I have quite a long list of questions as far as methodology is concerned. And because since we are all of us are reviewers for various journals, so we get to critically analyze the articles, and at times we can be a little bit thorough as far as the questions are concerned. So my first question really is a little bit from the conceptual point of view for this particular paper. It's more of an ethical issue rather than anything else. Usually we treat the symptomatic irreversible pulpitis patients in a single visit. However, in this paper, in the first visit, only a pulpectomy was done and a calcium hydroxide dressing was placed. And just to see the pain scores over a period of certain time intervals. And then the patients were called back after, I think, 3 days. And then probably the endodontic treatment was completed. So how can you justify a multi-visit treatment in a case where a treatment can be performed in a single visit? That's my first question, sir.
Dr. Vivek, please.
Professor Arshad, thank you for the question. I'm so delighted to meet you. Your question regarding the ethical concern of a single visit treatment. A lot of consensus has been changed now, and the single visit endodontics is now discouraged globally. So it is always preferred to perform the root canal treatment in 2 visits. In the first visit, we do a proper cleaning and shaping. We place a medication of calcium hydroxide, and we call the patient after 7 days. In the current study, we call the patient after 10 days, not 3 days as told by you, but after 10 days. But the global consensus says that single visit endodontics should be discouraged and should be replaced by a two-step endodontic therapy.
Okay, fine. My next question is
Dr.
about
Dr. Arshad, let me add something. You know, even if we, but maybe if somebody said that they don't agree actually with this, and they said that they want actually to finish it in one visit, we don't say this is wrong or correct. But as far as the authors are consistent about the treatment intervention, I think that is enough. And we don't need actually to be worried about anything else. As far as they are consistent. So they have a good consistency in terms of the methodology. By mentioning all the details, that would be fine. And it is not for the sake of the research. You are right. If we do something, if we change the way of our treatment for the sake of the research, this is not ethical. But when they said that it is the way that they usually do that in the clinic, that's fine, they can do it. Sorry for that.
exactly,
Please go ahead.
exactly. That was my concern. Exactly, that was my concern. Okay, my next question is regarding the conduct of the randomized controlled trials. In the paper, I could not see any guidelines that were followed, that we usually follow for the randomized controlled trials. And I also could not see any flow chart.
Yep. That was many of the participants, other participants' questions as well, Vivek. Thank you, Arshad, for that. Vivek, please.
Dr. Nekoofar, I will. Yes.
Oh, you mute
you're
yourself.
muted.
Please unmute, Vivek.
Unmute,
Am I
please.
audible?
Yeah, we can hear you now.
Okay.
I'll take few minutes of yours on this randomization thing. We have mentioned that we have used permuted block stratified randomization technique in this particular study. Now, I will briefly explain what this technique is, and I will show you the actual allocation concealment method also. Now, this technique is used to balance the number of covariates in the control and test group. So what are covariates? Covariates are the variables which may or may not affect the outcome. For example, the gender or the tooth type. So we consider them as covariate, and the purpose of all the randomization is to balance the number of covariates in both the groups. So this permuted block stratified randomization, it combines both the block and stratified randomization. So the participants are first divided into strata based on their key covariates. So in our study, there were two basic covariates. The first are gender, male, female, and the type of tooth, first molar and the second molar. So they were divided into 4 strata. And within each strata, permuted block randomization was used to assign the patient into treatment groups. So this process, in a way, it generates separate randomization schedules for subset of participants, which are defined by their covariates. For example, the first subset is male patient with first molar. So I have certain allocation envelopes with me. So after we generate this randomized sequence, we put it in something like this. This is an sealed envelope, and they have a number in there, right? So these are absolutely sealed, and we can see that it's written male first molar. So I don't know what is the type of treatment inside it. So I will open this, and I will perform the treatment according to this sequence. One more thing, before I open this, I will write an alphanumeric code on this envelope. We will understand why. So let me just make out one alphanumeric code. Let me put it as MHNVA, that is MH Nekoofar and Vivekaggarwal. So after I put the alphanumeric code, I will just tear the seal. And we can see there is an insert. There is a white insert inside the envelope. When we take out this insert, we can also see there is a carbon paper inside it, right? So when I take it out, I can see it is written IL, intraligamentary. So the patient of male first molar will go into the interligamental group. And the purpose of writing the alphanumeric code on this envelope, and the purpose of this is, right, the alphanumeric code will be copied on this, right? So this will leave an audit trail. The actual patient data and the alphanumeric code obviously are written by me on a separate sheet, and this audit trail will be kept by the nursing assistant, right? So at the end of the trial, I will compare the data from this audit trail and the actual data. So if there is any discrepancy between the audit trail and the actual data, we have to remove the patient from the final analysis. In fact, the Cochrane guidelines say if there is discrepancy more than 5%, we have to abandon the trial. But by God's grace, till date, there has been no discrepancy, but we have to take precautions like this, keeping an audit trail, keeping an sealed envelope. The envelope is sequential number and it's opaque. I cannot see what is written in this, and it has to be opened just before the treatment.
So Vivek, you first inject the inferior alveolar nerve block. And if it works on that 29% cases that works properly, you carried on and then you didn't put them in the study. Am
Absolutely.
I right?
Yes.
And
true.
then when it happens, the envelope will come. So when the
Yes.
failure of INB happened, you bring the envelope, you open it up, and then you give it to a person who doesn't aware about the injection as well. Yes, am I right?
No. When I start the patient, I assume that it is going to fail. So according to the strata of the patient, the second strata is female second molar. So if it's a female coming with a second molar, I will keep this handy. I will pass on to my nursing assistant. If the treatment is successful, if the anesthesia is successful, I will continue with the treatment. If it is not, I'll tell him to just open it. And before opening, I'll write the alphanumeric code into it.
Okay. And no, what about the blindness? Because you said that the practitioner who did the treatment was blind about the injection time.
No, I have written that outcome assessor was blinded. In this assessor, outcome assessor, it is in this particular setup, it is almost impossible to blind the operator. You see, the intrapulpal injection is entirely a different concept than an intraligamental injection. For intrapulpal injection, I have to gradually remove the dentine over the pulp, put a very fine opening, and then perform an intrapulpal injection. So it is not possible to blind the operator. The Cochrane handbook suggests using the term proxy operator in this type of scenarios, where the blinding of operator is not possible. We use a proxy operator, and this operator is not involved in the final analysis or any kind of statistical analysis. Assessor is blinding, the patient is blinded, the statistician is also blinded.
Okay, makes sense. In the chat box, there is a question. It said that why the numbers of the female and the men are not similar?
It all depends upon the patient's data which is coming to our OPD. We cannot selectively say, oh, I will take 25 females and I will take 25 males. So it depends upon the number of the patient which is coming, the type of the patient which are coming with a suitable inclusion criteria. So if the patient fulfills the inclusion criteria, he or she will be included in the study. I cannot refuse just based on the gender of the patient.
Okay.
Yes,
So,
definitely there are more males than females in our study.
And then you didn't also report that separately as well. In the results, we couldn't find the report of the pain in the female group in comparison to the male group. Why not?
It was not reported. The difference, the effect of gender on the pain is not reported in this trial. Yes, you are absolutely correct. Okay, and we have not evaluated that. Yes.
That would be good, because sometimes it may have some effect on and also on the application in the clinic for us as well. Dr. Hugo, please.
One small thing, Professor Nekoofar, when we start a randomized clinical trial, we have to submit a proposal to the NCT or any clinical trial registry. And once that proposal has been approved, we cannot change a bit in that proposal. So in the initial proposal, we haven't mentioned any kind of intention to treat. So you can see that 3 patients failed in intrapulpal anesthesia, which was not anticipated by us. So actually the success rate of intrapulpal anesthesia was not 100% if we consider as intention to treat, it was less than 100%. If we, if we count those 3 cases in which I was not able to achieve the strong back pressure. So my point being, that the protocol which has been approved and which has been submitted into the clinical trial registry, we cannot deviate from that. Yes, we can learn from that and include those things in the future trials.
Okay, thank you. Dr. Hugo, please.
Thank you. Professor Vivek, I have some question about the operators who performing the infiltrations. Was a single operator or multiple operator who performing the infiltrations?
Professor Hugo, it's a very valid question. A single operator performed all the treatments. Now, this is very important.
Very important.
Very important, yes. As we can see, the amount of pressure which was generated in the intraligamentary injection or the intrapulpal injection is much higher than 100 psi. In a very old study by Pashley et al., they evaluated the amount of pressure generated in different kind of injections, and they included 10 residents from their department. And you will be amazed to know that the range of pressure was from 150 psi to 720 psi. 120 to 750 psi. So that is a very wide range of pressure, and the amount of pressure will be dependent on the operator. So to remove any kind of operator bias, a single operator performed all the back pressure injections.
Thank you. According to my experience, this manuscript needs to be very well explained about the who performing the infiltrations. If was a single operator, add a statement about the was a experienced professor with 5 years in teaching or certified by the board in endodontics, explain very well about the experience of the operator. Another question. Thank you for your ask.
Very valid point, Professor Hugo. Point noted, and this will be rectified in my future submission. And very valid point that the experience of the operator should be noted in the manuscript.
Thank you. About the oral per medication, in the manuscripts is stated about consumption of any medical drug affecting pain perceptions, but it's very open. It's open, not clear, the statement. Can you explain more about this exclusion criteria, please?
Yes, absolutely. In India, a lot of drugs are available over the counter. In fact, at certain places, opioid are also available at over the counter, and these can affect the pain perception a lot. Like tramadol, though it is not considered as an opioid, is considered as semi-opioid, but it badly affects the pain perception. And patient does not tell you the type of medication, pain medication he's taking. He doesn't know it is an opioid or it is just a paracetamol or ibuprofen. So if a patient tells that he has taken any kind of pain medicine in the past 24 hours, we just don't include that patient to rule out any chance of including such kind of patient in our study.
Thank you.
Dr. Arshad, we are waiting for your next question.
Yes. So my next question was again related to the flow chart, because we are missing the flow chart. We have no
Dr. Arshad, I'm sorry to interrupt you. The flow chart is available as a supplementary material on your website.
I did go to the website. I couldn't see the flow chart. Okay,
it was not available. The JOE, or in fact all the international journals, they want a consort flowchart and consort checklist to be uploaded along with the paper, and I'm very surprised this was not published in this paper. If you go in my previous paper, the consort flowchart, at least the flowchart is available, and the checklist is available as a supplementary material. But I'm really surprised, as with you, that there is no flowchart.
Because I was looking for the you mentioned in the paper that certain patients who for whom the anesthesia was not effective even with the intraligamentary, they were excluded. So I couldn't see the data for those patients.
Okay, so I believe almost 13 to 14 patients who received intraligamentary injections out of 47 patients, they did not achieved anesthesia during the treatment. So their data was excluded. Now,
Okay.
those patients were treated with the help of a second intraligamentary injection or maybe an intrapulpal injection. But since they received multiple back pressure injections, their data was not included in the final pain analysis.
So your initial N number, how big was it?
The initial N number which we calculated on the sample size calculation was 28. And it was increased to, I guess, 34 to allow any dropout cases. So in the
Okay.
final analysis, we have 33 injections and in interligamentory and 45 in intrapulpal. So
So if you
that puts another limitation, that is an unequal size in the test groups, 33 in the interligamentory and 45 in the intrapulpal. But that
Mhm.
relates to the high success rate of intrapulpal rather than the allocation of the patient into two groups.
Okay. Another, just a small question. I might have misunderstood one part of the methodology. Initially you gave the inferior alveolar nerve block, and then in some of the patients, then you randomized into either intraligamentary or the interpulpal in those patients in which the block failed. So while giving the intraligamentary, did you give any additional buccal infiltration?
No, no, absolutely no. You see, in my first clinical trial, which was published way back 16 years ago, I performed a clinical trial published in GOE. I gave a buccal infiltration of articaine and a buccal infiltration of lignocaine. And I found that even giving a buccal infiltration of lignocaine can improve the success rate of an inferior alveolar nerve block. So while giving an pressure anesthesia, I did not perform any kind of buccal infiltration. And Professor Hassan, that is a very valid point, because I feel while giving an intraligamentary injection in actual clinical practice, it is always better to give a half cartridge of articaine as a buccal infiltration. It reduces the discomfort. Professor Nekoofar,
Yeah.
when I give intraligamentary injection, the patient at times complains to me that he or she is feeling some kind of a pressure building in his jaw. And at times that is something unsettling for the patient. So as Professor Hassan rightly said, if we give a buccal infiltration, that relieves that pressure, that anesthetizes the area, and the patient is absolutely pain-free. But in the current study, we have not given any buccal infiltration just to rule out the anesthetic effect of that buccal infiltration.
Okay. Will it make an ethical concern, kind of an ethical concern?
Exactly.
Um, I really don't think so, because patient complains of a pressure and not a frank pain. In the book by Malamed and in all the standard textbooks and in all the standard paper on the interligamentary injection, the researchers have not given any kind of buccal infiltration before any interligamentary injection. In fact, the STA technique, that is the single tooth anesthesia technique, the computerized CC LATS, as we call it, they also do not recommend giving a buccal infiltration prior to any intraligamentary injection. But personally, I prefer to give half a capsule of articaine, 4%, before giving an intraligamentary injection.
Thank you very
So
much.
I think it leads me to a question that raised by Professor Zargar, which is about same things, that this study evaluates the postoperative pain for interligamentary and also intrapulpal anesthesia technique, but does not consider measuring the pain experience during the injection itself, especially for the intrapulpal injection, which is known to cause significant discomfort. How can the overall effectiveness and acceptability of these anesthesia methods be properly assessed without evaluating the immediate pain caused by the injection, which is a critical aspect of the patient experience, and also it may have some effect on the post-operative pain as well, because it may change also the perception, the patient perception of the overall pain management. Please go ahead and discuss this one, Vivek.
Professor Nekoofar, that is a very valid point raised. You know, the major drawback
This
of
point actually raised by Professor Nazanin Zargar. She is here, but she asked me actually, she sent it to me today morning, so I make a slide of that. Thank you very much, Nazanin, for that.
So the major drawback of the intrapulpar technique is that the needle placement and the injections are directly into a very vital and a very sensitive pulp, and the injection may be very moderately to severely painful. I categorically remember there was a letter to editor in GOE way back 25 years back, in which a resident from neurosurgery or from neurology department, he mentioned his experience with intrapulpal injections, and he wrote a letter to the Kenneth Hargreaves, the editor of GOE, and he told Hargreaves that though the injection was very successful, but this success came at a substantial price, and that price was a transient excruciating pain. The word he used was excruciating pain. So in our experience, patient experience, yes, a very intense pain, but that pain lasts for less than few milliseconds only. In our practical experience, the pain is there, yes. So we have to condition the patient before giving the injection. Even if I'm giving an intraligamentary injection or intrapulpal injection, like in this study, I don't tell the patient the type of injection I'm giving just to blind the patient. So in all the patient, I condition the patient before starting the treatment that if you experience pain during the treatment, we might give you a certain type of injection that will have that can give a very bad amount of pain, but just for a half a second or 1/4 of a second. So patient is conditioned before giving intrapulpar or intraligamentary injection. But yes, that is a very valid point that intrapulpal injections are very painful. Secondly, the second concern raised by the doctor was this intrapulpal pain can affect the postoperative pain. Yes, that was the basis of this study only, to find out the effect of intrapulpal pressure injections on the postoperative pain. And we found out that yes, there was.
No, Vivek, the question is the amount of the pain during the injection, because it's not the same for everybody. So maybe it can become a way for the comparison of the effect of, or amount of the pain during the intrapulpal injection and the effect of that on the postoperative pain. So that can be for the future study, something like
Yes,
that.
you have just given me an idea. And
Yeah.
I will try to register it today itself so that no one else can take this trial.
I did same thing when I was in Mexico. That is my job.
And I will take all the suggestions from Dr. Hugo. Very valuable suggestions.
Yes, Dr. Hugo is amazing. Yes. Yes, good, good. So far, so
And
good.
he has an eye of an eagle. Even the editors could not find out that mistake.
Yes, you're right. You're right. But by the way, let me tell you something funny as well about intrapulpal injection. As you know, in our private practice, all of us have patients that they are not happy to pay to us because they are our, for example, old friends or classmates or something that they don't say, okay, I don't pay to you. So I decide for this type of patient to use intrapulpal injection always as the first injection. And then they escape from my office. They don't come back. They say, okay, because somewhere we pay that is painless. We don't want to do free treatment with pain. You know, that is the thing. So I think it's important to think always about the amount of pain during this type of things, this type of injection. Is there any other question?
One small thing I want to add.
Please.
The efficacy of intrapulpal injection is amazing.
Yes.
It's amazing. It's a guaranteed result. If I'm able to achieve any kind of pressure inside the pulp, I'm 100% sure that there will be a complete anesthesia. Now, one small thing I want to add in this, this was not studied in our trial, but from old reports, that there's a concern that this high pressure can actually damage the pulp.
Yes.
So in few of the studies, in the first study by Rosenberg, way back 20 years back, 30 years back, he injected normal saline and lidocaine in premolars to find out whether the pressure is acting or the solution is acting. So he suggested that even if we give a normal saline, there will be a complete pulpal anesthesia. So he noted in the footnotes of that paper that in certain cases where they were not able to remove the pulp entirely, in receiving intrapulpal injection, the pulp was vital in the second sitting. Similarly, in a recent study published in IJ, the authors have evaluated the effect of intrapulpal anesthesia on the success rate of pulpotomies. So
Yes.
before doing a pulpotomy, they have given intrapulpal injection, and the success rate was similar to those group who are not receiving any kind of intrapulpal injection. So intrapulpal injection, it in a way, it strangulates the pulp, it stuns the pulp, but it does not actually harms the pulp. But yes, it is very painful. It is excruciating painful.
So what about the intracanal injection? Sometimes with intrapulpal injection, we may enter the pulp chamber, but when it goes inside the canal, patients still have pain, and then we have to inject intracanal. Have you encountered any case of that? And then do you remove them from the study, or because it needs another injection?
Dr. Nekoofar, if I am able to achieve and strong back pressure in the pulp chamber, I feel that entire pulp gets anesthetized, including all the canals. So if I'm not able to achieve strong back pressure, and if I enter, suppose the distal canal of a mandibular molar, it's a very wide canal. So I can wedge the needle inside the distal canal and the anesthesia happens. But in mesiolingual or the mesobuccal canals, it is very difficult to achieve that strong back pressure in using other techniques also. So in those cases where I was not able to achieve strong back pressure in the pulp chamber itself, I have excluded them.
Okay. Good. Any other question from the audience, please go ahead. Okay, the next question is about the periodontal health as a confounding factor. Because in your evaluation of postoperative pain following intraligamentary and intrapulpal anesthesia, did you consider the health of the periodontal ligament and surrounding periodontal tissue? Why we ask this question? Because since the effectiveness of intraligamentary anesthesia depends heavily on the conditions of the PDL, how can the conclusion about the comparative efficacy of the two anesthesia technique be valid without assessing or reporting the periodontal status of participants? Could variability in periodontal health, such as inflammation or compromise PDL integrity, have influenced the efficacy of intraligamentary anesthesia and thus affected the study outcome? Vivek.
Very true, Dr. Nekoofar. If you read the exclusion criteria in this study, it clearly states that patients with periodontal pocket appendal diseases were excluded in the study. You see, it is very difficult to achieve an intraligamentary anesthesia in patients with a deep pocket. We are using extra short needles by septoject, which have a length of 10 millimeter. So if the periodontal pocket is 6 millimeter or 8 millimeter deep, it is literally unable to go inside, the periodontal ligament space. Secondly, it is not advisable to inject the needle in such cases as it can lead to bacteremia. There are certain case reports and certain studies which have suggested not to use this type of supplementary anesthesia in patients having a poor periodontal health and gingivitis. So we have not included such kind of patients in our study.
So you remove from the both groups actually. So when you have
absolutely, while recruiting the patient, I'm not sure that this will go into interligamentary or intrapulpal. So it is better to exclude such kind of patient before itself.
What about the preapical status?
It was absolutely vital. We have mentioned that the patient having a symptomatic irreversible pulpitis. So by the definition given by AE in 2017, patient having a symptomatic irreversible pulpitis, they give a prolonged response to the cold or the heat or the electric sensibility test, and they have a minimal bony changes at the periapex.
Yeah, that is the question, because recently also we have seen a lot of articles, and we discussed one of them actually in our first session with Professor Nesrin Taha, that even when we have a preapical, or let's say enlargement of the PDL at the preapical site, the pulp tissue may be vital, and we can even do vital pulp treatment for this type of cases. So by seeing enlargement of the periodontal ligament at the apical site, we cannot distinguish easily between irreversible pulpitis or reversible pulpitis or whatever we called it, periodontal ligament enlargement. So it's a very tricky thing for the inclusion criteria. I have received some question about that as well. If you describe that a bit more, that how do you remove them, or what was your cutoff point for that purpose?
So when the patient arrives in the OPD, if we are able to categorize at a symptomatic irreversible pulpitis, so we have certain clinical and subjective outcomes for that, criteria for that. We apply endofrost. We use endofrost, which is a cold application method. And if the patient gives a sharp shooting pain, excruciating pain, and lingering pain more than 15 seconds, we include that patient in our study. So one of the exclusion criteria in our studies is mentioned that when I'm opening the pulp chamber, and if I'm not able to find a vital pulp in the pulp chamber, that patient needs to be excluded.
Oh, good.
So
Good.
there may be vital pulp at the apex, but not in the pulp chamber. So that patient should be excluded. I want inflamed, but irreversibly inflamed pulp, which is present entirety in the pulp space.
Good. So it should be mentioned in the article because that was a big issue. I think it should be mentioned. We couldn't find such a thing. We couldn't find this definition, this very good definition.
Mentioned in the inclusion criteria, second criteria says vital pulp in the pulp chamber as well as all the root canals.
Okay, understand. So that is a good, now we understand it because now you describe it and we understand it. Perfect. Thank you very much. In the chat box, there is a question that they said there is no report about the result of the percussion test in the cases. It was also in the slide.
Yes.
The percussion test, because when the percussion test is positive, that means we have something outside the root
Apical
canal.
periodontitis. Yes.
Perpendicular nerves are actually ready now to answer to the inflammation.
So only those patients were included which had a normal periapical health. So if there's any pain on the percussion, those patients were not included in the study. So their periodontal space was already inflamed and hence they were not included in the study. Only patients with symptomatic irreversible pulpitis with a normal apical health were included.
Okay, good. The next question that raised by Professor Zagar as well is actually about the baseline pain levels at the time of the injection of the intraligamentary or intrapulpal injection in comparison to preoperative pain. Because they said that the study compares the efficacy of intraligamentary and intrapulpal anesthesia technique in reducing postoperative pain. Yet there is no mention of recording the pain levels at the exact point when the decision was made to administer the supplemental injection. How can you ensure the validity of the comparison between these two techniques without demonstrating that pain levels were initially equivalent at the point of the intervention? Would it not be crucial to show the baseline pain at the time of the supplemental injection was comparable to rule out inherent differences between the groups that might confound the final outcome? To draw valid conclusion, it is essential to ensure that the initial pain levels were comparable between groups at the time of the supplemental injection. Without this information, there is no way to rule out the possibility that one group started with significantly higher or lower pain levels, which would affect the response to the intervention and ultimately the study findings. This question was by Professor Zargar as well. Vivek, please.
I must say thank you to Dr. Zarga for pointing out such beautiful things in this paper.
Actually,
she's
I
absolutely
translate
right.
it, not her. This is
So
my translation was.
Okay. So as we have mentioned in our paper that patient who experienced a score of more than 54 millimeter on the HP VAS score scale were included, but divided into the intrapulpal and the interligamentary group. So all the patients which had received these supplementary injections, they had a pain score of more than 54 millimeter. not less than 50 more, but more than 54 millimeter on the HP VAS scale.
Dr. Zaga, do you want to add something to that, or are you convinced or not? Okay, while we are waiting
Okay,
for Dr. Zaga.
let me, sir, let me just briefly take this opportunity to show you one HP VAS scale.
Perfect.
I'm really sorry to take 5 minutes of your time, but a lot of postgraduate students in different colleges in India, they are really confused about the use of HPVS scale, and I believe it is one of the most misunderstood pain score in dentistry. HPVS. Just give me a second. I'll just take it out.
Okay. So while Dr. Vivek bring that one, I want actually to mention that this is also very important to know the way for the pain measurement. So this is really a good opportunity for our postgraduate students that they are also inside our participants to listen very carefully. Dr. Vivek, may I ask you to remove your blurring your background, because when you blur that one, we cannot see what you show.
So
No,
I'll turn off.
just go to the video. No, just go to video and remove the blur my background, like the one that I did now. So now you can see my background clearly. If you go just to the video part, and then on the right side of that, you can.
Yes, there's option for my video.
Perfect.
Is it fine?
Now we can. Yes, this is sharp now.
Perfect.
Good.
So this is an Heft-Parker visual analog scale. The actual name of this scale should be Heft-Parker modified visual analog scale. So by definition, by the glossary of pain, the Journal of Pain, the visual analog scale does not have any kind of categories on it. So if it has a category, it is known as a categorical scale and not a numerical scale. So this scale has both categories and numbers. So numbers are 0 to 170 millimeter. And to help the patient to mark the pain, there are certain categories written on it. Faint, weak, mild, moderate, strong, intense, and maximum possible. So with the help of these category markings, the patient marks their pain. Just for example, he or she marks their pain over here. So this is the pain scale which is given in all the journals and in all the articles. But believe me, this is not the actual scale. The actual scale looks like this, right? So there is a center line. We fold the scale like this, and only this part is shown to the patient, not this 170 millimeter line, right? So this line, it helps us to accurately measure the amount of pain. So when the patient has marked the pain over here, we just open it, we put a scale or ruler over here, and we mark the corresponding millimeter marking over here. Now, why this is of such an importance? Now, when we are doing a large clinical trial of 100, 200, or 500 patients, and we are doing multiple trials, what we do, we photocopy this paper, right? Now, I assume that this is a 170 millimeter scale. So the easiest method is to take a scale and put it here and measure the amount, the difference between the 0 and this millimeter marking. But while taking a Xerox of this paper, this scale might get enlarged or might shrink. So it is always better to take a reference mark which is equal to this. So the best way to use an HPVAS is using this scale. If anyone wants a PDF copy, just ping me or just email me at my email address, and I will share the PDF file of this HPVAS scale. The actual
Very
name
nice.
is HP Modified Visual Analog Scale.
Very nice. By the way, about the measurement of the pain or preoperative pain, Dr. Zaga wrote in the chat box that she is not convinced. So if you want to add something to that, please go ahead. And before that, there are two more questions. One by Dr. Aisha Noor. She said that in some patients feel severe pain even before reaching the chamber. So intrapulpal is not possible in that condition. And the other question said that by Hawaria, I think, or Ali Khan, that he said that what if one of the canal has necrotic pulp tissue? How did you deal with that? Did you include it or exclude it? I think we already covered this one. But please go ahead and answer all of this.
Yes, so there are two questions. One is by Professor Zaga. She has rightly said in a previous study published in Journal of Anesthesia Progress by me, I have correlated the amount of preoperative pain on the anesthetic success, and I have found that the amount of preoperative pain directly affects the success of the anesthesia. So she is right in a way that the amount of pain which this patient is having during the treatment, it can affect the future success or the future pain scores. I will keep that in mind, and I will try to include this in future trials. But in the current trial, we have not correlated the amount of pain which is happening. It was obviously it was more than 54 millimeter on the HPVS, but we have not correlated this amount of pain with the post-operative pain scores. Secondly, the question by a resident or a professor, she pointed that it is very difficult to achieve intrapulpal injections. So what I do personally in my clinic, I use a very large round bar. And with a very gentle pressure, I gently remove the dentine tissue over the largest canal. So if I go directly into the distal canal or the palatal canal, the patient will experience very excruciating pain. So I remove maybe 0.1 or 0.05 millimeter in a single go with a copious irrigation. And while doing so, I apply a cotton soaked in lidocaine. I press it over the dentine. I take all the methods to go as slow and possible and use as much coolant as possible. So when there's a pinkish hue on the dentine, I use a very, very fine small burr. I just give a dimple and there is a diffuse bleeding from the pulp chamber. And immediately I tell the patient that you might feel a prick, you might feel something bad pain. I give interpulpal injection and that's the way to go.
Okay, okay, great. By the
But
way,
that is a very valid suggestions by Dr. Zerga. Thank you so much. If you listen to it, thank you so much. I will include all your suggestions in the future papers.
good.
You know, Dr. Nekoofar, this is such a beautiful learning experience for me.
Thank you very much for accepting to be with us and sit in that hot chair that we ask you very harsh question. But you did a
No,
great
no.
job. You published an amazing article. We appreciate that.
Dr. Nekoofar, believe me, this is not a hot chair. This is a learning chair.
Thank
I always tell my students at my college that we are dentists, we are doctors. Doctors and lawyers are those professions who always practice. We cannot
very nice.
become, we can never become a perfect in our field. We are always practicing. I cannot
But
say guaranteed to my next patient that your treatment will be successful or not.
you
So
are
that is
very
a
humble.
learning stage
Very humble. You are
for each and every
amazing
one of us.
scientist. Thank you. By the way, there is also another question about the diversity of the patient. The problem is that because you did everything in a local area, also in one particular type of the patient, maybe in another area, it is even impossible to inject intrapulpal because you, in the way that you explained that, you can convince your patient to tolerate that amount of pain. But in some other areas, imagine in some countries, you are not, even if you do that, patient may sue you and then they ask money for that amount of the pain that you introduce for them. So it is not possible to overgeneralize your result to every area or any other area. So the result of your study somehow cannot be generalized. That was the question. So please go ahead.
That is a very good question, Dr. Nekoofar, and this represents what we call as external validity
Exactly.
of a clinical trial. So there are two types of validity, internal and external, and this is a very valid point of a diminished external validity in our trial. So in this trial, we have explained to all the patients that you might receive an injection which can have a very bad pain just for a moment, but it can have a very bad pain. So all the patients who have given a written consent were included in the study.
Okay, thank you very much. So this is amazing. I didn't feel actually now it is more than 1 hour that we are talk together. That was an amazing discussion. Thank you very much. So I want actually to show quickly the quick evaluation of the study. So evaluation of this
Just
study.
one thing,
Yes, please.
Dr. Nekoofar, it is on a very lighter note. I was courtesy to Dr. Hugo. I was again going through my paper to find out any mistake, and no, there is no mistake, but there is a joke which I got. I have reminded. I've written the null hypothesis was that there was no effect of supplementary interligamentary injection. So
Oh,
I always tell my wife that the null hypothesis is like your husband. Oh, no, no, bear with me. So in the starting, we always assume the null hypothesis is right. And we make all the complex experimental scenarios around him to prove him wrong. So null hypothesis
amazing.
is just like a husband.
Very good, very good. That's true. That's true. And most of the time, we should get rid of the null hypothesis. That's true.
Okay, incidentally, my wife is also a professor of endodontics,
Oh, very nice.
my colleague in my dental school, and she's a second author, and she must be in the audience right now.
Wow, wow, wow. Congratulations. Maybe good to ask her to turn on her video as well at the end. And we can also thank her for supporting you for doing such an amazing studies and publication. By the way, our overall evaluation about your article is this. The clarity of research objectives, clearly defined objectives, evaluate the effect of anesthesia technique on postoperative pain, relevance to the field, high relevance in dentistry, address pain management in endodontic treatment, contextualization within existing literature, situates study within literature, emphasize challenge of effective anesthesia, potential for clinical application, yes, objective aligned with clinical needs, outcomes could inform anesthesia decision. Congratulations, this is the very good article based on the first evaluation. Evaluation of the methodology, study design, randomized double-blind clinical trial design, minimize bias and enhance validity, sampling methods, 135 participants with clearly defined inclusion-exclusion criteria, appropriate sampling methods for research objectives. The status of the preapical area and its diagnosis are unclear. It is unclear at what stage of the treatment the intraligamentary injection was given and whether the intrapulpal injection was given at the access stage, which actually confirmed that we were wrong about this part. So we should remove this line as well, but that Vivek explained this one very well. Data collection, pain measured using Hef-Parker visual analog scale, multiple assessment post-treatment provide a comprehensive view, analysis technique, descriptive and inferential statistic used to analyze data, clear reporting of results with p-values and confidence interval. Evaluation of the result also showed that the result showed very well and demonstrated very well as well. Very nice and well organized with logical flow, heading guides readers, pain outcomes differentiated by time points for clear understanding as well. Supporting by, and the conclusion and the results supporting by the data very well. They didn't also add or remove anything from the data in terms of the conclusion and the discussion. So significance of the study is clearly articulated, emphasizing clinical implication. And this is also very important that we need to think about the potential for improved patient outcome and clinical guidelines, which is discussed in this study. Single center design that we already discussed limits generalizability or extra validity of findings to other settings, sample size consideration, adequate size, but maybe underpowered for smaller effect sizes. Exclusion criteria, strict exclusion criteria may lead to a homogeneous sample affecting applicability. We need to be careful. Self-reported pain measurement, reliance on self-reports can introduce bias in pain perceptions. Potential bias in randomization, specific randomization methods not detailed, risk of selection bias, which was because it was in the website of the journal, and we can see this specific information if we need. Lack of long-term follow-up, limited insight into long-term outcome or delayed effect that you already covered. That one, limited assessment of secondary outcome, focus on pain, other outcomes like satisfaction of the patient not explored. These are actually the first evaluation that we can talk about
Dr.
it,
Hugo,
and
just
can
can
add
you
something to that. Yes, please.
just can you just go behind that the previous slide, the limitation slide?
Okay, I go for that.
With your permission, can I take a photograph of it?
Oh, I can send it to you if you like,
Oh,
but yes,
that's
please go
wonderful.
ahead. Yeah,
Oh,
I
that's
will.
wonderful. No, no, no.
After we finish the session, I will send you this PowerPoint to your WhatsApp.
Wonderful. Thank you. Thank you. Thank you.
By the way, if there is any other question, please go ahead. We still have 9 minutes. Okay. So Vivek, I personally don't have enough word to thank you and to say that how you add value to our specialty, to our professional as an endodontics. We are very proud of you. We are very proud of your team. I wish Sanjay Miglani could join us as well. And also I talked with Dr. Saatchi from Isfahan University to join us. Unfortunately, there was an accident for his sister that he was in hospital, so he couldn't actually accompanied his sister. He couldn't join us, but you mentioned that your wife is with us. So if she can also add some word, that would be amazing.
I'm just looking for her in the
Please.
list. No, she
If
has
she
left
is
the
here,
meeting.
please ask her to say some word about you. Maybe she, I don't know, you are still the null hypothesis or not.
I believe I'm still the null hypothesis.
Oh, you are.
And believe me, Professor Nekoofar, this is the spice of life.
Yes, it is. It is.
I'm
actually.
happy to be a null hypothesis, and I'm happy to be wrong all the time.
Oh no.
Even if I'm right, I say I'm wrong. You just prove me wrong, I'm wrong.
Okay. All right then. So I want to ask my colleague now to share the. So we all put our hand together for Professor Dr. Vivekaggarwal. This is the online certification for this amazing session that we had with you, Vivek. Honestly speaking, you are amazing. You are a very humble scientist, an amazing researcher. You publish a lot of articles that add value and give us a lot of information. So you produce science, and the next generation owe you a lot. Thank you very much, everybody. So I want to actually ask now our president, Dr. Hugo Munoz, to terminate the session by some words. Dr. Hugo, please.
Thank you, Dr. Nekoofar, and thank you also, Dr. Vivek. First of all, congratulations for your publication. I know we all appreciate the authors who make the effort to publish a randomized controlled clinical trial. This is not easy to do, but we appreciate your work and your effort on doing that. And on behalf of SELA, I also would like to thank you for your time, for sharing us your experience during this research, and hope to see you again in the near future. And also thank all of the attendees for being here this hour and a half, and hope to see you again for the next session. Thank you.
Thank you very much, Hugo. And I ask Vivek if he has a last word for all of us.
Thank you for all the kind words.
Any other participants, if they want to say anything, please go ahead. Hugo, do you want to add anything?
No, only say thank you, Professor Vivek. Amazing paper. Thank you so much.
And also for accepting our invitation. That is also
Yes.
very important, because many
Yes.
authors, they say that, yes, but we cannot discuss our article. When I send invitation to them, they deny, actually. They say that we cannot do that because they are worried about the questions and the sessions. But you did an amazing job. Thank you. Okay, the stage is yours, Vivek.
Thank you, Professor Nekoofar, Professor Hugo. Thanks a lot for inviting me here. I would just say, I would quote a line by Sir Isaac Newton, and he said that if I have seen further, it is by standing on the shoulder of giants. So it is all the work done by the stalwarts like you, Professor Nekoofar, Professor Malamed, Professor Hargreaves, everyone. We are nothing in front of you, sir. Anything which we do is by looking the work done by you. Even today, if I write a paper, I first read paper by all the eminent personalities in the field, and then I start writing the paper. So I must thank you for giving me this opportunity, and thank you, SELA and the Tehran University of Medical Sciences for this honor. Thank you. Really humble, sir.
Thank you, everybody, and see you in a month for the next session. Goodbye, everybody.
Thank you.
Have a very nice day. Goodbye.
Thank you.